this? There we go. Got it. All right, thank you. Thanks. So I am going to return us to real-world implementation, shift gears a bit, in which the million-dollar questions are relatively simple. So how do we support providers to offer long-acting cabotegravir-Rilpivirine? How do we support patient uptake and adherence? And how do we support clinical systems to procure, drug, monitor, and ensure safe discontinuation? And I could say a lot about determinants and strategies for the latter point, the systems and policy context, but in this presentation, I'll be focusing on end user perspectives and experiences, which we were fortunate enough to be able to explore in the context of the Modern Art Study, which was an NIMH-funded R01 that was a mixed methods evaluation of implementation in 3 urban academic Ryan White-funded HIV clinics, my clinic, Ward 86 in San Francisco, the Grady Ponce de Leon Clinic in Atlanta, and the University of Chicago. And these clinics have slightly different demographics. Ward 86 is mostly men who have sex with men and is 20% Latino, including some monolingual Spanish-speaking patients. And Atlanta and Chicago have mostly African-American people with HIV and are 30 to 40% women. So one of the wonderful things about this study, and a point I'm going to keep harping on, is really the importance of being able to study patient and provider attitudes before clinical availability. And I'm going to call that the pre-implementation period. And so this was qualitative data that we collected at the 3 sites on attitudes towards Cabril. And what we really found was a spectrum of acceptability. So there was a small proportion of participants who were, quite enthusiastic innovators who want the latest and greatest in treatment. And there was a small proportion of skeptics, but most people really had attitudinal orientations that fell in the middle, that were deliberative and pragmatic, and really that their attitudes were quite malleable. The more that they learned about the nuances, the facts and requirements for this therapy, and people really highlighted the importance of consulting with their provider. Everyone said over and over again, well, if my provider thinks it's right for me, that carries so much weight. And it's really a point I want to make, is that these are situated in the context of a patient-provider relationship. In all of our work, we really made an effort to sample for individuals with adherence challenges. So, we repeated this in quantitative data. These were exit surveys that were conducted after provider visits, and we found, again, this is pre-implementation, most people, 72%, were probably or definitely likely to try long-acting. Only 13% said definitely or probably not. And interestingly, if the topic of long-acting had come up in the visit that day, and we don't know who brought it up in the visit, but if it had come up, people were more likely to be willing to try. Our pre-implementation qualitative data with providers, we sampled different cadres, nursing and pharmacy, as well as primary care providers, the MDs, NPs, PAs. And among our nursing and pharmacy staff in the 3 sites, there was really a strong commitment to making this happen. We will find a way. The staff really acknowledged the need to tailor service delivery to patient needs. And our providers, their enthusiasm was really contingent on, can we use this for people with adherence challenges? And I have some quotes there that might be a little bit hard to read, but the point is that, there was, the first quote is expressing frustration at the requirement for virologic suppression. The whole purpose of this medication delivery system was to decrease the barrier, and then at the same time we're being told, or we're going to use this patient's barriers against them. It's really paradoxical, right? At Ward 86, my clinic, we spearheaded using long-acting Cabril in individuals with viremia due to adherence challenges. And I think many of you have heard the clinical successes of the program presented many times, probably. And again, I can tell you in another talk about there are a lot of facilitators that our clinic had at the clinic level and the policy level that allowed this to happen. But I'm going to tell you a little bit about why this works from the patient perspective. And I want to focus your attention. This is a graph I created in our first paper on this topic that shows, the really striking results of individuals who are starting, so this was a direct to inject strategy, individuals with even 5 log viral load becoming suppressed to less than 30 copies in a month's time. So just think for a minute what that might, put some thoughts in your mind about what impact that might have psychologically on somebody who's really struggled to take a pill every day, right? Oops, sorry, I went backwards. So this slide here presents the results of 59 qualitative in-depth interviews that we did with early adopters of Cabril at 3 sites, and again, sampling for people who started with viremia at initiation. And what we found was that the benefits of the therapy really dependent on the antecedent burden conferred by oral ART. So on the left hand of the slide, in the first 4 colored circles there, you see what I call the typical benefits. And these are benefits that were described in the qualitative literature from clinical trials, of course, increased convenience, reduced anxiety about forgetting pills, increased control over disclosure. But on the right side, we found some care engagement benefits that, can only, were only found in this real-world qualitative study. And for all patients, regardless of whether they had well-controlled HIV or had adherence challenges, really there was this positive feedback loop that happened when treatment was happening successfully that resulted in increased trust in the clinic, providers in the patients in the provider in the clinic. And then for those with viremia due to adherence challenges, there was such a powerful amelioration of shame and negative self-worth upon finally achieving virologic suppression and finally being able to be a good patient. And so I'm just going to share 2 quotes briefly. This patient talking about, I don't have to have shame face. I'm doing what I'm supposed to do for my health, right? I'm finally able to do this. And then, there's this ripple effect that occurs that where other positive impacts on health and well-being accrue. And this participant talks about how, he started taking medication for his bipolar disease. He stopped drinking. He broke up with a toxic relationship. He's a lot more hopeful about his future. And, this is why treating people with adherence challenges works. So now I'm going to turn to the abstract that we submitted here, and this was presented at CROI as a poster. And so it's a survey of early adopters who have had at least 3 injections, currently receiving treatment. Again, as I said, with all our data collection, we sampled, tried to purposely sample for people who were starting with viremia. In our preliminary analyses, there is no difference, and so I'm just presenting results for our full sample. So we had 206 folks in this survey. About 30% had viremia at initiation, median of 9 injections, and about a third in the sample were unstably housed or homeless and had used opiates or meth in the past 30 days. So satisfaction was quite high. These are the satisfaction scales that have been used in the clinical trial PROs, both for absolute satisfaction as well as asking them to reflect back on their oral ART. And then in the interest of time, I'm just going to move through this quickly. There were improvements in worry about inadvertent HIV status disclosure. And then improvements in remembering, how difficult is it for you to remember your treatment? This was asked as a 5-part Likert scale, and results were categorized into not at all or a little bit difficult to remember versus somewhat very or extremely difficult. And while a third reported that both oral ART and Cabril were not at all or a little bit difficult to remember, almost 2/3 experienced a substantial reduction in effort to remember therapy. And characteristics that were associated with that reduction in effort were being unstably housed or homeless, and again, using stimulants or opioids. And then we asked people in a check all that apply question, why do you prefer Cabril? And the most commonly endorsed answer was, I don't have to worry about remembering oral ART, and it's less work. And that was a theme that we had seen in our qualitative work. 97% were confident that they would continue, and none saw themselves going back to daily oral pills in the future. We asked about the preferred location to receive Cabril, and this was quite interesting, again, highlighting the importance of the clinic. Really, that was chosen, by 91% of people, right? And 54% chose only the clinic as their preferred location, and only 10% preferred a non-HIV clinic location, which again is quite interesting. And only 4% said that HIV clinics visits are more of a problem on Cabril. So the next three slides are probably maybe the most relevant to this conference and what we've been hearing today. And in the upper left there, what you see is, we also did a pre-implementation survey with people in the three clinics, 370 people with HIV. So that's just everybody in the clinic. This was before long-acting was clinically available. And then in the right are our 206 early adopters who are on Cabril. And so, in the pre-implementation data, the most popular long-acting modality of the options given was an oral pill, with about a third of people wanting that option. In our early adopters, what I find interesting, so these are the people who didn't want pills, right? So that's not a popular option for our early adopters. But what I find very interesting about this is that only about half would prefer an injection into the muscle. The other half would be interested in another modality if it were available. In both the pre-implementation and the early adopter data, dosing interval about 1 year of a year is most preferred. That's about a third of the sample. And then what about injections by lay people or in other anatomical sites? And the pre-implementation and early adopter results are pretty consistent for self-injection or injection by someone in one's personal life, about 2/3 being interested in self-injection in both samples, and 60% versus 55% for injection by someone in one's personal life. And then when we asked the early adopters about thigh injections, 70% said that they were interested. And so I find that interesting. We heard earlier, the people who actually got thigh injections as a rotational short-term strategy, only 30% would have preferred it to gluteal. But, we don't know about, well, what about if you could go back and forth, right? And so I think, to sum up our survey findings, in a diverse sample of people with HIV in 3 geographic locations with about a year of time on injections, we found high satisfaction, improvement in the psychosocial aspects of ART use, particularly those who have challenges to adherence, but that nearly half would prefer different long-acting modality and a longer dosing interval. And I just want to say a word about discontinuation, because it is a limitation of the survey results that I presented, that we didn't include people who had discontinued because the number was small at the time. But we've done some really in-depth qualitative work with those folks, and we'll be publishing another paper on that. And so at the 3 sites, discontinuation rates are higher than in clinical trials. It's about 13 to 19% over 12 to 18 months of use. And qualitatively, what we see is that for some, the burden of injections comes to outweigh the benefits. So, at Ward 86, we had another poster at CROI where we systematically went through all our reasons for discontinuation. And pain in people with virologic suppression, pain and, plus or minus another side effect or concern is the most common reason. In our folks with adherence challenges, it's virologic failure or disengagement for care that's driving discontinuation. But certainly, gearing up for and experiencing pain is really driving this, along with needle fatigue, meaning it's not just injections, it's also the frequent blood draws. And so but these folks might be more likely to have be interested in other forms of long-acting as well as oral pills. So this is my last slide. So moving on, sorry, I have a lot to say. This is the last slide, which is that, to wrap all of this up, there's really enthusiasm from patients and their providers and many cases of success. And the injection burden doesn't, this should be, the benefits don't always outweigh the burden. And then because there are issues that have stymied implementation, it's just really a priority now to understand that all of these options that you all are developing that are in the pipeline, how do they fit into treatment decision making, and can we start to work on implementation barriers and facilitators now to ensure a timely and effective rollout? So those are my acknowledgments, and sorry for being over. Okay, thanks.
Thank you. Thank you.